Hello, I'm Hope Rugo, a professor of medicine and director of the Women's Cancers Program and the Breast Oncology Division at the City of Hope Comprehensive Cancer Center. And I'm here with my colleague, Becky Shatsky, who will introduce herself in a moment, to talk about triple-negative breast cancer in the metastatic setting, new treatments, new approaches in the first-line metastatic setting that are improving outcomes for our patients. Becky, it's great to have you here. Want to introduce yourself?
Thank you, Dr. Rugo. My name is Becky Shatsky. I am the Director of Breast Medical Oncology at the University of California, San Diego, Director of Breast Cancer Clinical Trials, and the Inflammatory and Triple-Negative Breast Cancer Research Program.
Great. And actually, we work together quite a lot on neoadjuvant therapy for high-risk breast cancer as part of the I-SPY 2 trial. And then we talk a lot about cases and how to manage patients. And I think that's a great improvement in the cyber era, that we can actually talk about complex cases and managing toxicity. And the other thing we do a lot of is review new data and try and figure out how we're going to put that new data into clinical practice. But first, I think, we have to have a good background on the milieu or the overall situation that we're dealing with. Like, what is the background? Why is this such an important area for discussion? And what we have found, of course, we did the work showing that immunotherapy with pembrolizumab improved not just progression-free, but also overall survival, but only in the patients who had PD-L1 positive disease. And that represents maybe 35% to maybe a little bit higher, a little bit lower, depending on the patient population of our patients. And then we run into another situation where patients get optimal neoadjuvant and adjuvant therapy, but develop metastatic disease very quickly, either while on their adjuvant treatment or shortly thereafter. How often do you see these patients who have PD-L1 negative disease in the metastatic setting?
Yeah, that is a great question. So unfortunately, we know, just as you mentioned, that PD-L1 negative metastatic triple-negative breast cancer is the majority of patients. And even in sometimes when we say ineligible for immunotherapy, maybe they've had immunotherapy toxicity in the curative setting that was severe, and we don't want to re-challenge with but unfortunately, this is a pretty broad patient population that is a really big unmet need, because the other thing we know about PD-L1 expression in metastatic triple-negative breast cancer or in the curative intent setting is that's actually a good prognostic factor. And so those patients tend to do better, but this PD-L1 negative immunologically cold population has a worse prognosis and historically has done pretty poor as far as their overall survival in this setting.
Yeah, it is interesting that we've identified that PD-L1 positivity can be a positive marker, although not always in the de novo metastatic setting. There are probably resistance markers that where we see some patients just not doing very well with this, or maybe heterogeneity in the tumor. And I think that leads us into one of the big questions of why is it so important that we start on the right foot in treating patients with metastatic TNBC, is that there is some data out there that suggests that only 50% of patients make it to the second-line treatment. Reason's not clear to me, but what is your experience with that? I mean, do you have patients who aren't able to go on to the next line?
Yeah, reviewing that data, that was also a little bit shocking to me because, in the United States, I do feel like most of the time I can keep people towards their second, sometimes third or fourth line. But in my experience, the ones that happens to, often they develop like really, really difficult to treat CNS disease. Like, say they had really massive leptomeningeal disease develop during the first line, and they just become so sick that we lose them during that time period. That's sometimes an issue. Or maybe they had some kind of severe toxicity or just started with such a very, very high disease burden at the time of diagnosis that in that little progression time period, maybe we lost control and they went into liver failure.
Yeah, I wondered if that data, because it doesn't reflect either yours or my practice, but We certainly have some patients who don't go on, but I wonder if there are the patients who might actually unfortunately die during their first-line treatment because the cancer escapes, and you mentioned liver failure is probably our biggest cause of that, or leptomeningeal disease, something like that, that precludes potentially patients going on to the next treatment. But, I think even though it's not our experience, we do know that some patients don't go on and that, performance status, how people are tolerating treatment, cumulative toxicity all plays a big role. And when you're choosing what you're going to give a patient in the first line setting for metastatic TNBC, how do you balance the different treatment options? For example, if people are used to giving chemotherapy, I find that, for de novo metastatic disease, people are giving gemcitabine and carboplatin, even though taxanes are the standard of care and probably are better than gemcitabine and carbo. So I don't know what drives that, except for that they don't have to lose their hair. Or the oncologists know that combination. But what would drive you to use an ADC instead? And what is your goal there?
Yeah. So I've been really passionate about advocating for ADCs in the first line for metastatic TNBC for a while now. And the primary reason is not the de novo metastatics, but it's the relapse setting. Because for years now in the United States, the Keynote 522 trial has been the standard of care. And you're getting, carboplatin, paclitaxel, pembrolizumab, adriamycin, and cyclophosphamide, 5 drugs in that setting, and then yet we still have some of these patients that relapse early. I mean, that's very common in metastatic TNBC. If they're going to relapse, usually it's within even the first 2 years. But they represent a more resistant patient population that they've already been treated with 5 drugs. And so the idea of treating them with something that they just received, it doesn't make a lot of treatment sense to me as far as mechanism of action and resistance. And so, as well as CNS disease, because that is a huge issue in metastatic triple-negative breast cancer. We know that these patients, if they live long enough, often get, brain metastasis or leptomeningeal disease. So brain penetration is also something that I think is extremely important. So, certainly for these relapsed or patients, I think treating them with a different mechanism of action, these topoisomerase 1 inhibitor ADCs, makes a lot of sense. As far as the de novo metastatic patient population, these updated trials that we're going to discuss did include those patients as well. And, I think putting your best foot forward and, strongest medication here, if we are truly losing 50% of the patient population by the second line, makes sense.
Yeah, I think, dividing up and understanding that better is a big goal for the future. But, I think in this setting, we don't understand sequencing well. But if a patient has, really resistant triple negative breast cancer, or, most patients have visceral disease with triple negative disease, you know, putting your best foot forward seems like the best approach. And for me also, controlling the disease for as long as possible in that first line setting means you're treating patients in the best shape. Their bone marrows are better, they tolerate treatment better, they have less of the end organ effects of treatment, and they're just less beat up by treatment overall. So I do think that that will make a difference. It's going to be interesting to look to see what happens at the rates of CNS, new disease in these patient populations with longer follow-up. But and then how do you interpret overall survival data from, trials and from, I guess, when you're thinking about choosing treatment?
Yeah, so overall survival data in this setting, as opposed to maybe the hormone positive, HER2 negative breast cancer setting, is a little bit more straightforward because these patients don't live as long. And so that's a very important endpoint for triple negative breast cancer. Like I said, they tend to relapse early. The recent TB02 data where they powered the trial specifically with a primary and dual endpoint of PFS and OS is unique. And that did play out to have a 5-month overall survival benefit. Now, the other trial, the ASCENT-03 data, that is another ADC. It's similar TROP2 antibody with a topoisomerase 1 inhibitor payload. That data is a little bit more immature, and there are some differences, of course, when you think about metastatic trials, allowing crossover, for example. But having a agent that has a significant overall survival benefit of 5 months certainly is something that I take to heart and consider pretty carefully when I have this discussion with patients.
Well, let's talk about that a little bit more, and we'll get into the whole aspect of targeting TROP2 crossover and trying to understand sequencing, which we can't understand. But I think that clinicians are very aware of trastuzumab deruxtecan, TDXd. We use it in HR-positive disease preferentially, as long as there's some even tiny bit of HER2 expression, and in HER2-positive disease. So I think there's been a lot of information out there. But, clinicians have variable exposure to targeting TROP2, I think mostly in the late line setting based on the data from the original ASCENT trial.
Yeah.
TROP2 is expressed widely in triple-negative breast cancer. How do you think about the differences between TDXd and Dato-DXd and Sacituzumab Govitecan, our two approved TROP2 ADCs?
Yeah, so in the metastatic triple-negative setting, we know that about 80% of triple-negative breast cancer expresses TROP2. So it's a really wide target there. And it's a good one for this specific disease type. And, as far as trastuzumab deruxtecan, the majority of breast cancer in whatever subtype does have some HER2 expression, but we know that some triple negatives, truly are 0-0. That's kind of the population. If I was going to really believe that result of no staining, that's the one exception. But yes, we all by now have some experience with trastuzumab deruxtecan. Now, it's a little bit of a different molecule than Dato-DXd or SG. So the trastuzumab deruxtecan has this high drug-to-antibody ratio of 1 to 8. Actually, Sacituzumab is about 1 to 7.6.
Yes, something similar.
Yeah, Datopotamab is 1 to 4. We know that these topoisomerase 1 inhibitor payloads, which all three of them are very powerful as cytotoxic agents. And so when I explain these to my patients, I kind of say that this is fancy, more effective chemo.
Yeah.
I don't want to minimize that part.
Yes, it's important.
Yeah, these aren't like the oral targeted agents where they have non-cytotoxic effects, I would say. But all three of these agents have shown improved efficacy as opposed to their comparatives of these cytotoxic chemotherapies that we've been using for a long time. And they also seem to have better CNS penetration and, ability to treat even things like leptomeningeal disease in my experience.
Yeah, it's interesting. I mean, I think we don't have enough data on LMD yet, but except for TDXd from Japan, I think.
Yeah.
But and HER2-positive disease. So I think, it's going to be very interesting to see results of ongoing studies looking at that, because it's such a huge challenge with TNBC is dealing with brain metastases. And as you pointed out, we don't really have enough data with TDXd in triple-negative disease. So we've really focused on the TROP2 ADCs. And now we have these two first-line trials, TB02 and ASCENT-03, for the patients who are largely PD-L1 negative, about 1% PD-L1 positive in ASCENT-03 and 10% in TB02, but not eligible to receive immunotherapy. And it could have been not eligible. And I think, thinking about international studies, you could have not been eligible because you couldn't access it, which is true, unfortunately, in large parts of the world. So I think that was, we're thinking about it as these drugs for patients who wouldn't get immunotherapy. And mostly in the U.S., those are patients who have PD-L1 negative disease with a small percentage who had, as you pointed out earlier, bad immune toxicity. So we have these two trials, and They're both looking at giving an antibody-drug conjugate to a TROP2 ADC to patients who have triple-negative breast cancer. But there were some notable differences between the trial populations and also in the treatment of physician choice arm.
Yeah.
Maybe tell us a little bit about that and how that affects how you're thinking about the trial data.
Yeah, absolutely. So one thing that was really interesting, and I have to give them credit for this, I thought it was wonderful, in the TROPION-Breast02 trial was that they had no disease-free interval requirement. And so that was pretty novel because I think you and I are used to these trials that select patients who haven't relapsed in the last 12 months has usually been the standard. And that's a little bit easier disease to treat. It's not the highly refractory immediate progressors that we see that, maybe they have disease that pops up on the chest wall right after surgery in the middle of radiation, those kind of cases. And so I was happy to see that. Of course, there was a cap to how many patients with that very short 0 to 6 month disease-free interval could enroll. But even the ASCENT-03 trial allowed the patients who relapsed between 6 and 12 months, which is still novel in its own right. Both of these trials had pretty balanced amounts of de novo metastatic disease in the 30% range. They were both highly international trials, which is important as far as what access they had to other ADCs or immunotherapy, as you mentioned. So about 30% of the patients in both trials were in either the United States or Western European countries. And the rest were probably, mostly in Asia and Russia. And the access to those ADCs and immunotherapy was quite limited in that patient population. Those are the primary differences as far as trial design. The other thing to point out, and this isn't a huge difference in patient population, but I just like to point it out as it's one of my interests, is there was about 10% of patients in the TB02 trial had known CNS disease, known brain metastasis, and about 5% in the ASCENT-03 patient population.
Yeah, I think this 0 to 6 month group has made me think a lot about the fact that, we did this in Keynote 355. So that's where it came from, was the 6 months or more, but they, took a risk to include those patients who were 0 to 6 months. I have come up with the thinking that there's probably not a big difference between whether you relapse at 3 months or 9 months. I think, the cancer is probably the same if you relapse early, but it was really important to include that group. The treatment of physician choice was also a bit different between the trials and also the crossover.
Yeah, so that is a good point. So in TB02, you had a really wide range of options, actually. So you had paclitaxel, nab-paclitaxel, capecitabine. One I really like that they included was eribulin, because that's an agent that I like in metastatic triple-negative breast cancer. And then they had carboplatin, but as a single agent, which was a little bit different. Usually we do carboplatin gemcitabine together. As far as ASCENT-03, they had paclitaxel, nab-paclitaxel, and then gemcitabine, carboplatin. Didn't have the eribulin or the capecitabine, I believe.
Because the ASCENT-03 mimicked Keynote 355, even though that was a PD-L1, there was a PD-L1 positive component, right, of that trial. They just mimicked it for both ASCENT-03 and 04. And I was pleased with TB02 to see that less than 5% of patients got either CAPE or carbo alone, since they don't work very well, so that it didn't, really impact the comparator. But it is interesting because between the two trials, the control arm had a different outcome, and which was so interesting to me that, these, even though you're doing the trials at around the same time, you have very different populations, and it may be driven a little bit by the population of the earlier relapse, but not clearly on the forest plot. So they just are very different populations of patients, which is really interesting to me. And the crossover, I think, also brought up a lot of controversy, as you know, and a lot of discussion at ESMO.
Yeah, so that's a big difference as well when we talk about the overall survival benefit data that we have right now. Because, in the ASCENT-03 trial, we know that in at least those 30% of patients, well, the patients in the United States, if they were going to um, have treatment in the control arm group, in the chemotherapy group, they could at a later date have that Sacituzumab Govitecan, which is approved in the second and third line setting in the United States. And so that does influence, we know, in the metastatic setting, those overall survival results. In since the Tropion-2 Datopotamab hasn't been approved in metastatic triple-negative breast cancer, there's no crossover necessarily to that agent. But it's very different as far as where you're doing the trial and what the availability of ADCs is if you wanted to receive them in the second, third line setting. And so crossover was allowed in ASCENT-03 and not in TB-02.
And in ASCENT-03, I mean, I think just because the drug was available, if you had BICR, blinded independent central review progression, you got free drug.
Yeah.
And that played a huge role in Russia and Asia and places where you have to pay for the drugs. This is a really big issue. But it was impossible for TB-02 to do that, as you pointed out, so that the use of ADCs was a lot smaller, yes, because, in those countries, you might not have been able to access the drugs. But, and that sort of led to the differences in the endpoints. As you talked about earlier, the co-primary endpoint of PFS and OS being important to you. How do you describe the differences between having a co-primary endpoint versus having OS as a secondary endpoint when you're talking to oncologists?
Yeah, so I think that difference is actually important because it really means in the TB-02 setting that the trial was powered to detect that. Usually what we're seeing in these metastatic trials is that, they do it as sort of a secondary analysis. That's not really what the trial was powered to detect.
Right.
Yeah. And so I think that that's really different in this setting, and it's unusual. We don't see it as much.
Yeah, I think without the availability of Dato, maybe, and the less impact, it was
Easy.
something that, it was more straightforward to do, not if you allow crossover, which is the other trial. So there are also differences. I mean, we now have peer-reviewed publications for both these trials, and there are differences in the schedule of administration and toxicities also.
Yeah.
How do they, what do you think about those, and how do they impact what you would reach for first?
Yeah, so I think a lot of the differentiation of the two also really does sometimes boil down to toxicity and schedule of administration. I know, speaking to a lot of doctors, that that's really how they discuss things with patients. So Sacituzumab Govitecan is a day 1, day 8, 1 week off administration, kind of like a Eribulin that way. We now have the administration of pegylated G-CSF. With that has decreased the febrile neutropenia rate, but there were still deaths on the ASCENT trials due to neutropenia, so that's a big consideration when you're thinking about that drug. Neutropenia is what I would call the primary toxicity of Sacituzumab Govitecan. When we're talking about Datopotamab, the toxicities are a little different. So some things that we may not have as much experience with. So dry eye was a big one. A good percentage, in the 70% range of patients, had some dry eye. The grade 3 event rate for that was low, though, in the single digits. And then stomatitis, mucositis, whatever you want to call it, because those are sort of overlapping, to be honest, as you've pointed out very well in the past, and we try to incorporate those together. That was sort of the second really big toxicity of Datopotamab, where you had 57% of patients getting some form of stomatitis, and then some patients getting grade 3, again in the single digits. I think it was about 8% grade 3 stomatitis. But that's something that we need to be able to be really on top of. Both dry eye and stomatitis aren't things that we naturally think about when we think about all chemotherapy toxicities. And so the one thing that's different about the Datopotamab is we want patients to have a visit with an eye specialist, before they start the drug or in the very early stages of starting the drug. And I say eye specialist because I think a lot of people thought that had to be an ophthalmologist, but at least at my institution, it's difficult to get in with an ophthalmologist off trial. Pretty easy on trial, but an optometrist can make that determination of whether the patient has baseline severe dry eye or keratitis, which maybe that's not a good idea in that patient population. And then in the Dato trials, it's highly encouraged to use dexamethasone mouthwash 4 times a day to help. It's better to prevent stomatitis than it is to treat it once you're kind of in pain.
Yeah, I mean, I think just in comment about a few of those things, the really important points, I will say that deaths on ASCENT 3 were related to people having neutropenia and diarrhea and not getting any growth factors.
Yep.
Which is a big issue in education and access, but it is what it is, I mean, it's very important. And you don't see a lot of marrow suppression with Dato, similar to TDXT, which is really fascinating
Yeah.
to me that, you just aren't getting the release of the toxin on the cell surface. So you probably don't have as much bone marrow
Yeah.
effects for that reason. So that's one thing. The second thing just to mention is the diarrhea rate from the SN38,
Yes.
which is the payload for SG. And I think that's quite a unique toxicity because the Deruxtecan ADCs don't cause
Don't have
much
it.
at all.
No.
And there's somewhere in a 9 to 10% rate of grade 3 diarrhea, and that can be limiting for some patients, really create a big issue for them, and does appear to be at least partially related to polymorphisms
Yeah.
in UGT1A1. And just talking about Dato, we don't do an eye exam before we start Dato in somebody who's asymptomatic and has no eye history. And I think that that's probably important for people to know that you don't have to do an exam before you start, that the eye toxicity was largely reversible, and so that you could, if a patient has symptoms, you do want to hold the drug and make sure you get an eye exam. And then we do tell people to use the eye drops,
Yeah.
as many times a day. That we had 8 times a day, which is very hard for anybody to do, but at least 4 to 6 times. And to not, the other, I guess, question I'll ask you about when I get through the mouth sores is what do you do with that eye drops and contacts? Because, people wear contacts, the recommendations were not to wear contacts, but it's not like the toxin is accumulating under the contact, So we don't really, it was like a recommendation without a lot of knowledge.
Yeah.
And the stomatitis is fascinating. We have no idea what the risk is. You have half of the drug to antibody ratio is half that of TDXd, where we don't see any stomatitis. So I do think, we had our experience in I Spy, and I thought the preventive steroid mouthwash played a role,
Yeah.
a really important role, but we saw a little bit anyway, so some people may need to be dose reduced. But you made also another really important point, which is that prophylaxis is better than reaction.
Yeah.
And what we see, when you look at those data on toxicity, it has to do with somebody who didn't use the steroid mouthwash, all they need is 1 day of a mouth sore, and there it is on your toxicity. So, we don't have a good way of scoring based on the duration or if you use prevention or not.
Yeah.
And for unfortunate reasons, it just wasn't tracked well in the either TB01 or TB02
Yeah.
in terms of the use of prophylaxis versus rescue. All they did was that you had it sometime on your con meds. So we don't know, and we do recommend it really strongly. I don't, the FDA's label has ice chips. I don't know that
We
doesn't
don't
make
have
sense
any
to me.
data on that because these have a long half-life, and so I've seen that as well, and kind of wondered about that. It's in my mind kind of similar to recommendations of cold capping in ADCs. Like these are drugs that have a long half-life, and so just chewing ice chips during the infusion doesn't make a lot of sense to me.
No, me neither. And who knows what's in the water, but I'm joking. But so what about the contacts? What do you tell people about that? Is that a
Yeah,
different?
I know. So, I don't have a lot of data that makes a huge difference, and just based on the way the trial was designed and telling people to discourage contact use, I suppose I sort of do it. But there are people who are going to wear their contacts anyway. It's not something I can fully control for them. I'm an eyeglass wearer, but a lot of people live and die by their contacts.
They do, and it's a big, their appearance to the outside world. And
Yeah.
generally tell
taking
people
away
not to
so
wear the
much.
contact on the day of treatment and for a couple of days afterwards. I figure that's where we have the most drug exposure, and
Yeah.
so maybe they could just wear glasses during that time and spare some of the risk. But again, we don't really understand that risk at all. And I think wha- I guess when we're thinking about all that management of side effects, how do you really involve the patient in those decisions? And which drug are you gonna reach for first in what setting?
Yeah. So one thing I haven't mentioned yet is the difference in dosing schedule with Dato. So that is given just like trastuzumab deruxtecan once every 3 weeks. And my patient population, because of the way my university is, has a very large catchment area, and some of my patients drive 2.5 hours to get cancer care. And in those patients, a once every 3 week dosing is quite important to them. They don't have the resources to come more frequently. And so it's not a simple, this versus that. Sometimes they really don't, they care more about how frequently they need to be at the cancer center. And so I do think that that is a benefit in Dato's overall toxicity and administration profile. Once every 3 week dosing is quite convenient. The other thing that I kind of neglected to mention is the ILD rates in Dato were not high, so that was something I was concerned knowing trastuzumab deruxtecan and my experience with ILD, but I haven't seen that so much, and the data doesn't support it that it's a huge problem with Dato. And so
I'm guessing probably delivery with the TROP2 antibody does, there's a lot of HER2 everywhere.
yeah,
And
in
then
the
you're
lungs.
delivering half of the drug. So
Yeah.
that seems, there was, I think, one mortality case that the adjudication committee thought was related to drug. But if you read about that patient, the patient had a lot of complications, that I'm sure contributed to it rather than just drug.
Yeah.
Seemed kind of a little bit of a stretch to say it was drug. And so the rate is really low. I mean, the lowest we've seen with any of the drugs that cause ILD. So you do have to watch out for it. And we certainly don't want to have in the real world setting more toxicity. But
Yeah.
I don't think it's a really big issue for Dato either. So that's I think helpful.
And not having to use pegylated GCSF is also a benefit. Some of my patients have such severe bone pain, especially the young ones who have this, super robust response and beautiful bone marrow. They can really get bone pain with pegylated GCSF. And so I know that they're happy about it. And I really do think that GCSF of some form is really absolutely necessary with SG. There in this day and age in the United States, I don't think anybody should die from neutropenic fever that could be prevented.
I agree. I have found treating, before we had the results of these trials as we were moving SG earlier, that in patients even patients who were relapsing early, that they needed less growth factor than, of course, what we saw in ASCENT in the second and third line setting. So I usually kind of see how they do. If they're getting to be low at day 8, then we're stuck. We got to use the growth factors. And we definitely do not want to have patients with a diarrhea and, low neutrophils, because this is where you really have serious life-threatening toxicity and need to be aware of it.
Yeah, and related to the polymorphisms, I've actually really liked that some of the circulating tumor DNA assays have added those testing, so the UGT1A assays and DYPD to have that information in one place is actually, I think, quite a benefit when I'm utilizing ctDNA these days.
Yeah.
And I do it's not that I dose reduce straight up with these SG if I see a polymorphism, but I'm aware of it. And if I do get any sign that they are getting diarrhea, then I'm more apt to dose reduce really quickly, I would say, because in the patients that I've had more diarrhea with, they do tend to have a little bit of reduced metabolism.
Yeah, I don't know what to do with the patients who are heterozygotes.
Yeah.
Because I've seen diarrhea and no diarrhea, both situations with patients who are heterozygotes. So I don't think we know. But for homozygotes, I actually would dose reduce when I started,
Yeah.
at least by 25%. I think those patients can get really bad
Yeah.
diarrhea. And it is an interesting era. I mean, as we now are urged to do DYPD testing for a 0.1 or less % risk of absent metabolism, but the option of I think finding patients who have intermediate metabolism for capecitabine, I think I'm hopeful that polymorphism testing will become more widespread. And I agree with you, these NGS, looking at ctDNA, NGS testing that gives you the polymorphisms is pretty cool.
Yeah, if I'm getting it anyway, having that additional information and their HLA subtypes in case I find some wonderful matched therapy someday.
Yeah.
I like having all of that in one place.
Right. We've talked about I think the toxicities and how we manage, thinking about those and talking to patients, and also the use of prophylaxis rather than being reactive. You really want to educate the patients up front. That can be a challenge to some degree, but how do you you see this patient for a second opinion, how do you talk to a community oncologist about how to decide and balance these areas and also how to prophylax most effectively?
Yeah, I do a lot of second opinions for metastatic triple negative patients, and every time I write a consult note, I do include the things that we should prophylax, and I'm very clear about that because the supportive medicines, when you're talking about drugs with real toxicities like this, can make or break the patient's experience and their ability to stay on the drug. And so I'm really clear that when we're talking about drugs that have high amounts of nausea, that we use olanzapine at bedtime.
Our favorite drug.
Yeah. Yeah.
2.5 milligrams.
Yeah, low doses, and other tumor types, they use these big doses that can sedate people too much. But, the same thing for dexamethasone mouthwash. I know that's been a bit challenging because there's been a nationwide shortage.
Yeah.
So at one point I was, ordering prednisolone, just kind of like you do in peds.
Yeah. You can also get compounding pharmacies.
Exactly. So hopefully that's resolved. I haven't had much of a problem with it recently. But I order for new starts with Dato. I order or I at least tell patients that they should try to use prophylactic eye drops. I really want them to use dexamethasone mouthwash, just like if I was, starting the patient on everolimus.
Yes.
And I send everybody home on SG with loperamide.
I think we all
have that at
home.
Yeah.
And then instructions on when to call in and checking counts, etc.
Absolutely.
We're working on some project to try and do blood counts at home, and I was thinking that would work for some of these drugs that we give day 1 and day 8, eribulin, for example. And, so we have a CENTO-4 in the PD-L1 positive population. Do you see that Dato will also be out there with immunotherapy?
Yeah, so I think we're excited. I think the combination would be with durvalumab. And I anticipate, that being exciting as well. I mean, I don't think personally that there's a gigantic difference between one PD-1, PD-L1 inhibitor versus another. But I do think that the combination of these ADCs, which are, immunogenic in their own right, have some antibody-dependent cellular cytotoxicity potentially. The synergy potentially with an immune checkpoint inhibitor is a great thing. And we could see some really great overall survival data in that setting as well. I do think that the two agents together make sense. And we don't seem to be seeing, at least in the I-SPY trial in our population, that the toxicities are necessarily synergistic as well.
Or in the CENTO-4. I mean, I think it's really encouraging. There doesn't seem to be an enhancement of immune toxicity with the combination, which is great. And of course, we have TB03 that's looking at this. And then there will also be trials probably with that in the not terribly distant future, looking at the TROP2 ADC in combination with immunotherapy and alone with Dato as post-neoadjuvant therapy. Maybe we'll be curing more patients with early stage disease. And then, of course, SG with Pembro. So a lot of data coming up. So as we close, and we have now the full data sets published for these two first-line practice-changing trials, what's the most important clinical question you're looking for at the upcoming conferences for the first-line treatment of metastatic TNBC? And where's the biggest gap? How are we going to think about these patients who have PD-L1 negative disease?
Yeah, so there is one aspect that we didn't talk about in the difference between the trials, and this was one thing that I'm having a hard time wrapping my brain around. Um, the overall response rates were different, and that is one thing that I have to say about the Dato trials, the TB02 trial, is that the overall response rate was very high in that trial, and it was in the 60%, 64% range, and that was a difference. In the ASCENT trial, it was about 48%, and chemotherapy there being like 46%. And so
Compared to in the 20s in Dato,
yeah,
right? The control arm did very poorly in the
yeah.
Dato trial.
And so that is one thing I do think about when I'm worried that I might only get one shot there. I do think
You
about
wanna get that high response rate.
yeah.
I think I was impressed by the high response rate, not the difference as much
Yeah.
because of the low on that, and the duration of response was as long. So if you had responsive disease, it looked like, I mean, you had double the duration of response. It was really remarkable. But it is curious, I think. It'll be interesting to see how that plays out and whether that was, people just couldn't get drug with SG because they were neutropenic or had diarrhea or, other complications, whereas they weren't holding as much. It's hard to know.
Yeah,
Really hard to
exactly, and
know.
what influences that.
Yeah.
A lot of this, I mean, I do take stock in that overall survival and the way that the trial was designed and that there are 0 to 6 month, um, progressors in the TB02 trial. But I also take the administration and toxicity data to heart, and I often will discuss with my patients, how important X, Y, and Z are to them, and find together what we think is the best, uh, uh, first line setting drug for them, with all of this combined.
Yeah. And I think in a lot of times we also use not just the response rates and toxicity and schedule, but also the patient situation themselves. I
Yeah.
mean, only the TB02 trial looked at those 0 to 6 months, and even if I don't think they're much different, and actually, if you looked at the patients treated in the first year, both trials were about 20%, right,
Yeah,
of the population. But if I have a patient who's relapsing on their adjuvant therapy, I'm gonna reach for the drug that was studied in that setting. So
exactly.
I think that's, for me, a difference also in terms of how I sort of parse out use of these different agents. And
Mm.
I agree with you. The schedule is important for patients. I had a patient, second opinion, say to me, "My doctor told me I should go on to get TDXD rather than getting the endocrine therapy, which was fulvestrant plus a targeted agent." And she said, I was given the option of an injection in my butt, 2 injections in my butt every 2 weeks and then once a month versus an IV every 3 weeks. And she was like, "That's not a question for me." So I think it is a really big issue. So I have so appreciated talking with you. Great ideas, insights. You're an amazing clinician. Always fun to talk to you about this area. And it's really an exciting time in the treatment of this very, very difficult to treat disease.
Well, thank you so much, Dr. Rugo, and if I can say anything, I learned from the best.